Hello, welcome. Welcome to the webinar today. My name is Katrin Schiffer. I'm from Correlation European Harm Reduction Network based in Amsterdam. And I have the pleasure and the honor to chair this webinar today. I was asked by EuroNPUD and I'm very thankful for that. I would like to see how many participants we have and probably wait 2 more minutes with starting off the program. I'm sure what I can do is already give a kind of introduction because I can't see. I'm just sorry for being probably a bit messy. If we can see how many participants we have. No, I can't see that from here.
We have 35.
35, so that's already quite something. So that's good to start already with. So I officially start now the webinar. This webinar combines 2 topics which actually both are very close to my heart. The one is peer involvement and peer-led interventions, and the other one is naloxone distribution. I would like to say a few words to both topics and then really only kick off the webinar and then hand over to the speakers. So about peer involvement, I think 10 years ago, I worked on a paper on meaningful involvement of people who use drugs in drug policy and also service delivery. And I reviewed literature, talked to different experts in the field, and tried to identify barriers and critical factors which make it actually difficult for services, but also for peer-led organizations to organize themselves. And as you can imagine, I found quite some barriers and problems on different levels. In 2010, Correlation organized I think one of the first peer involvement seminars in Prague at that time, together with people from EuroNPUD and lots of service providers throughout Europe. And the interesting thing at that time was actually that it was quite something to bring people together and just to talk, share experiences and promote cooperation. And now we see that many things happened and improved since then. EuroNPUD and also EuroNPUD managed to increase their capacities and also resources, so financial resources, which makes it much more easy for them to organize themselves and organize activities. And the same applies to drug user organizations in many countries. We see that many of them managed to become more sustainable and could organize themselves and also deliver services in a much more sustainable way. When we look to naloxone, just a short thing, because I think all of you know a lot about naloxone. It's existing since 1970. It is used in the clinical practice, and in the 1990s, Italy was one of the first countries which developed at that time take-home naloxone programs, which was quite something at that time. And now we see that lots of take-home naloxone programs have been implemented throughout Europe. And we also see that there are many countries who already started with peer-led naloxone programs, showing how powerful peers are and peer-led interventions are in this field. So today we will listen to a number of different presentations coming from EuroNPUD. Rui will later on present the technical briefing on naloxone and also a training manual. We will listen to 3 experts on the naloxone who will share their experience and on the national level, coming from Italy, Slovenia, Spain and the UK. And after that, we will also have the floor open for questions. Before we now really start, I would like to ask first to look to a video, a memorial video, which will be shown from EuroNPUD, and Christos will say a few words after that. So Roberto, can you probably share the... I can't hear anything. Christos, go ahead.
Okay. EuroNPUD acknowledges the contribution and the loss of Andrea Fallarini, a key drug user activist from Italy. Andrea was driven by a passion for harm reduction and a belief in the rights and health of people who use drugs. We remove the loss of Andreas, and we are also inspired by his example to maintain our activism for our community. We dedicate this webinar series in the name of Andrea and the far too many drug user activists who have been lost as we continue the collective fight for the health and the rights of people who use drugs. We also note the passing and contribution of Jude Burns from Australia, who was much loved by her European peers. Jude's loss has already been widely and appropriately acknowledged. We carry on the struggle to end prohibition and to champion the rights of people who use drugs in memory of our fallen heroes. Thank you.
Thank you. Thank you, Christos, for that. Yeah, I think very important memorial. For now, it's a bit difficult now for coming after such an emotional thing to actually something very exciting, but I'm actually very happy and excited to announce the Naloxone Man. He's the superhero of the world of drug users and overdose prevention, and he's famous, well known, and I'm very happy that he could make the time to come and say a few words of welcome. The Naloxone Man.
Hello! Naloxone Man here! How are you doing? So listen, what an exciting event we have lined up for you today. It's the PeerWorks webinar hosted by EuroNPUD. And what are we going to talk about, I hear you say? We're going to talk about Naloxone. Haha! Listen, Naloxone Man is a superhero. He's extremely average, but a lot like everyone here. You don't have to be a yellow superhero to make a difference. You just need to carry Naloxone. We hope you love the webinar. We hope you love the speakers. We hope at the end of it all, you carry Naloxone and save lives always. Remember, Naloxone Man loves you.
Thank you, Naloxone Man, for that really warm welcome. After this, I will give the floor to Rui. He's a long-standing friend and peer from Portugal. He has extensive experience in working with vulnerable groups. He has worked for the Roma community, for young people and people who use drugs. He has worked also for Abdesh, and he's the president of the Portuguese drug user organization CASO, and he's also part of the steering committee of EuroNPUD. And he will now present the peer-to-peer naloxone technical briefing, which has been developed by EuroNPUD. The floor is yours, Rui.
Hi all, thank you, Katrin, thank you, Naloxone Man, and thank you, Christos, for this remembrance of our loved ones, our community. Well, I will be presenting a technical briefing that was in fact launched in HRI in Porto in the conference. In this moment where uncertainty and some populism wave appears in Europe, and this is, lots of people are feeling frustrated with the way things are going, with inequalities, and but people don't participate enough, I think, or are often, their path is very blocked and with lots of challenges to participation. I don't know, Roberto, if you can have the slides up. Yes, thank you. Well, this technical briefing is around this simple idea that peers are have the knowledge and are many times the first ones to be with someone who is overdosing. So it's not just saying we have naloxone. It's also the need of thinking of strategies on how to get naloxone to the places where it is supposed to be, and at the right time, and with someone that really can save a life. And next slide, please. Sorry. Yeah, this was the left one is the technical briefing, and then we have some results of a project more specific in the UK. Next slide. As I was saying, this peers have this privileged access to the places of use, to how to move around the city and find supply systems, how and how to, in fact, give self-support and support to peers that are living many situations that a peer worker can relate to, and with the same codes and with the same losses on our lives. And so it's really sometimes a pity not to see that this kind of participation and investment, direct investment in empowering and giving more literacy to peers, so that we can take care of ourselves, build our health and well-being, and as well as for our community. Next slide, please. Yeah, so the model we proposed, it's not just the idea of having just a naloxone. It's not enough, like having needles and syringes in the 80s. Having them in pharmacies wasn't enough, and we need peer education. We need information to circulate and flow from grassroots, but also to our peers in more vulnerable circumstances. Of course, identifying signs and symptoms and looking at different possibilities, like a person already not breathing, or yet still breathing. Okay, next slide, please. Sorry. Yeah. We will find always some legal barriers, in some countries more, in some countries less, but I would say that it's important that not only as in this bubble of harm reduction and peer work, but also more general society becomes aware of how many lives can be avoided if we if we challenge stigma that persists and try to address more deep questions, I think. Next slide, please. So, yeah, we have the knowledge, and we have to reinforce that knowledge. I think that one training maybe it's not enough, but if you do, you know, several trainings and several moments where different peers can try out and simulate and be, you know, aware of how to do things in a quick way, and for having the procedures on their mind. So I would say that even people from the services, and even sometimes specific service for drug users. In Portugal, for instance, we had lots of outreach teams interested in naloxone training. We have a program of needle exchange and syringe exchange since 1993. And we just have naloxone accessible for a couple of years. And it's not a continued and strategic access, you know, it's just a pilot. So I guess how many lives were lost since 93, where we are giving the needle, and if the guy or the girl or whatever, if the person is nearby, we don't even have a way of intervention. So I would say this is pretty much a sign of the persistence of stigma, even in a country with a system of decriminalization. And I would say that it would be it would be really important not to have these incoherencies, and to have a congruent approach and biopsychosocial and holistic approach to these situations. And what we want is that no one else dies of overdose. No one in that coffee, where in the bathroom where people go when they come out of the train station. And we can identify lots of the places where people end up dying, and we can also open ways to train both professionals from shelters and other services, and also among peers, obviously. So next slide, please. Yeah, other thing, it's this idea of if we don't involve more broader society, we will continue to lose people. So we have to find channels to reach families, even if there's stigma and people don't want to talk about it. But I think it's really important to have general practitioners and family doctors and pharmacies, you know, the interfaces that society has with health should be more open to the idea of substance use and opioid use, and the importance of knowing naloxone and how to proceed if something happens to, you know, our daughter, our friend, whatever. So this is stigma and discrimination that puts off this machinery that keeps people away from the system, or feeling somehow that there's us and them, and not a cooperative system. So I think we were told a big lie on competition as the driver, basic driver of motivation and desire and will. And so we've been for a long time, trained to compete in society. And I think pandemic situation showed that this kind of drive and neoliberal way of seeing no alternative path, it's really destructive and not really facilitating social environments where peers can develop their own interventions. Next slide, please. Sorry. Yeah, this is kind of sum up, because highlighting other situations like people coming out of prisons, or of being on the hospital for some days, or it's pretty important that they are given naloxone, they are given the training and the training to train people that will be with him when he uses. Next slide, please. Yeah, so the basic idea that I would like to complete is that we've been talking of community for so long, and we have all the right words, the phrases that for politicians come, they seem to be all in the right place, but they came empty sometimes. And I really hope that this pandemic situation and with what we've experienced, fragilities, I really hope that this will open a more collaborative way, a more participative and meaningful participative, as Katrin was saying that, she was already 10 years ago asking for and suggesting. And so I would say a big thank you to all of you, and to peers and allies that have been making the machinery evolve a little bit. But this kind of paradigm of competition, of populism, has to be fight with collaboration and with doing the right things, occupying those empty spaces of cities, and being there with a non-judgmental attitude and with collaboration, and doing the right thing. So just one last remark is that we're making these toolkits accessible, and if needed, translated so that peers and organizations of peers can use it in their country level and local level. So thank you.
Thanks, Rui. Very fantastic product, and really something you can be proud of, I think. And I know I could imagine there are some questions to Rui now, but I would like to ask you to keep them for the end of the discussion, so we move on to the next speaker directly. The next speaker is George Charlton, and George is a passionate harm reductionist and currently works across the UK to support the development of peer-to-peer naloxone training and supply programs. And he has extensive experience in working with peers and people who use drugs. And actually, this is also in the center of his work. And for those who don't know, he's also a close friend to the yellow superhero Naloxone Man. So I believe he's probably the only one who probably knows him a bit better, but the floor is yours.
Thank you, Katrin. Unable to start my video because the host has stopped it. Could the host give me privileges to show the video, please? To share the screen. Cool. Thank you very much. Just give us 1 second. Can you see my screen there, guys?
Yes, yes.
Perfect.
Okay. Thank you very much. Sorry, it just takes a little second. It would have been advantageous to send me slides over, but I couldn't because of the media. Okay, thank you very much. Thank you so much, Katrin and Rui, for starting us off on a really wonderful project webinar. So I'm going to talk about developing peer-to-peer naloxone training and supply programs in the northeast of England and putting those with lived and living experience at the heart of the project. So what do you do with people who've lost their souls? Well, it's simple. You show them love, compassion, support, and you offer them purpose, connection, and hope. Something that stuck with me earlier that Katrin said was being like she was a real advocate of user involvement and participation. And user involvement and participation saved my life over 20 years ago, along with naloxone. I was a Class A drug user, a frequent flyer in treatment services, opiate overdoses, and I'm really grateful to be able to use my lived experiences to help other people. So why should we involve peers and people who use drugs in the supply of naloxone? Well, it's simple, because the people we care about are dying. So in England, in Wales, the recent figures show that there was 4,393 deaths. If you add in the 1,200 tragic deaths, just over 1,200 tragic deaths in Scotland, that equates 15 people who are dying every day of a needless and avoidable drug-related death across England, Wales, and Scotland. What we know is over half of all of those deaths involve an opiate. And if we've got access to naloxone and we get it in the hands of first responders who are peers, people who use drugs, and family members, then we can begin to make a massive dent and save the people who we really care about. So strengths of peer-to-peer naloxone programs, Rui touched on this stuff. But when compared with other naloxone distribution programs, peer-to-peer naloxone programs have specific aspects which make them more successful. So for example, we have privileged access to drug using venues. We have privileged access to drug supply systems and markets. We have formal and informal access to mutual aid networks. And we have access to drug scenes involving purchase and use, instant trust and credibility, authenticity in our approach. When we speak to people who use drugs, as people who use drugs, they take what we say as gospel, they believe us, they want to work with us, and it's a no-brainer involving people who use drugs. These two documents here, along with a little bit of support from, well, a lot of support actually from people like Matt Southwell, Stephen Malloy, Mickey Webb, Rui, all of the people on this course, man, on this call really helped me to develop this project, but it would have been nothing without the involvement of peers and people who use drugs, right? 2 years ago, I tried to get an naloxone kit from where I live, just one kit for me to carry on my person. And I was told by the drug and alcohol treatment provider at the time that I couldn't have one. I was told in an email, we are very sorry, we can't action your request, George. Normally, the drug user activist of old would have been straight on social media and shaming the drug treatment provider. But I thought, no, you know what? I'm going to do something about this myself. And I learned a lot from Matt and from Stephen about community mobilization and technical support. And I went and spent some time in Scotland where they had peers who were making supplies in brick buildings. I spent a few days up there and I was buzzing, man. Buzzing, like inspired, thinking I've got to come back and I've got to do this work in the northeast of England, because the northeast of England's got the highest rate of drug-related deaths in the whole of England and Wales. So I came back, I got excited, and I learned about peer-to-peer programs. I initially went to an organisation called Foundations in Middlesbrough, and Foundations specialist GP practice. That's got kind of over 1,000 people in treatment. I spoke to Danny Ahmed there. And I said, Danny, is this something that we can build together? But can we put peers and people who use drugs front and center at the heart of the project? Can we give ownership to them? And this was the building blocks of our project. So we work with organizations and executives who 100% want to get behind our project. We use community mobilization to recruit peers and people who use drugs, and we build real partnerships. I'm not prepared to work with any organization that's going to say, look at what we're doing with peers. It's got to be the other way to work with me on this. It's got to be, look what the peers are doing with our support, right? We have to give the kudos to the people who use drugs because it's their project. We use a technical support approach to ready the organization and audit it. So when we go into organizations and we say to them, we're not going to work with people who are 6 months clean or 6 months sober. This isn't an abstinence-based program. This is a harm reduction program. And as such, we need to use people who are using drugs at the front and center of the organization. And for some organizations, that can be a little bit difficult to get their heads around. But that's why it's really important that when we work with executives in the organization, we get them to recognize that nice people take drugs and that people who use drugs are ideally placed to make this work, then we can get them to change their policies and procedures and have people who use drugs work as volunteers in those organizations. We built wider relationships with stakeholders such as the police, public health and crime commissioners, and the press and the media. It was really important to kind of create some real positive momentum among the press and the media. We build naloxone steering groups, so ownership goes to the peers themselves. We do training and product familiarization, again, all of which I learned out of this. If anyone wants to build peer-to-peer naloxone training and supply programs, read these books, man. Come and speak to us. We'll help you. You know, it's a brilliant project to do. I love it. We began delivering naloxone training in-house first with the peers teaching staff members how to set up naloxone. It was a really interesting dynamic, really interesting. And then we hit the streets and make supplies where people are. So we don't do this in brick buildings. We do this outside of Kentucky Fried Chicken, outside of McDonald's, in disused car parks, in the place where people who use drugs go. And we tell the police where we're going and when we're going to be doing it, and they leave us alone. The police are really supportive of these approaches. So I wanted to kind of just show you a few pictures kind of which represent some of the journeys, you know. So my work started out at Foundations in Middlesbrough, but then eventually we got some real momentum and a national provider called We Are With You got on board as well. So the first part of the project was about community mobilization and technical support. So going out and meeting the peers and telling them we need them and helping them not to be cynical about the project. Oh, we've been promised these things in the past that never come to fruition. Well, they will come to fruition because I'm going to make them come to fruition working with you. The providers want to do this. That middle picture, teas, coffee and biscuits, an essential component of any peer-to-peer naloxone program, and loads of sugar, right? Because we're right into that stuff. I once had somebody who said to me, look how quick I can train and give someone naloxone. And they threw it at us and I caught it. And he said, it's that quick. And I said, that's bollocks. That's absolute bollocks, man. What we need to do, right? Peers already know how to use naloxone, but this is a prescription-only medicine, right? And we want them to understand the naloxone checklist, how to use it appropriately. We get them first aid training and basic life support training from the Red Cross or from the British Heart Foundation. We really, really invest in the peers. You can see here, peers getting used to using defibrillators. And that picture on the top left, top right on my corner, big tall guy with a naloxone kit wearing a red shirt. That's Chief Inspector Scott Cowie from Cleveland Police, who also sits on the steering group. And the relationship between the peers and the police really was fantastic to see them working together and working in partnership. Some more pictures. And then we get to hitting the streets, man. And this stuff's really important, you know. We know in the UK, you can come to brick buildings, you can come to drug and alcohol treatment services to get access to naloxone, right? But there's only like 16% of people who use opiates get access to naloxone. Not everyone's in treatment, so it's really important for us to take naloxone out onto the streets. That picture on the bottom there, you know, of somebody's home, man, that's really harrowing, but that's the reality of the places where we're working. You know, we bring human connection, we bring access to naloxone, and we bring roots into treatment and support as well. So what I don't want to do is I want to give some voices to the peers, and I've got a few more slides and then I'm done. So I want you to meet Jimmy from Redcar. He's a naloxone peer working with We Are With You.
I pushed myself to come to this group. This lad here was going to it. I was like, not for me, do you know what I mean? Got here, cracking set of lads, and everyone who's come, people like yourself, have all been really nice. Top man, you know what I mean? And Adrian's just a fireball, so
Adrian.
Adrian.
That's
George.
Well, now we're like the two
Adrian's
fucking
a
Ronnies,
cracker.
but
I've known Adrian.
And then Chrissy.
I was in tears, I was that happy.
Yeah,
Absolutely over the moon. Mint for having these by my side as well to support me and show me the love. Frigging got on wicked, had a mint laugh, buzzing all day, couldn't fall asleep until about 2 o'clock this morning. I was telling George this morning. Really looking forward to getting back out there, and that we hope we get some supplies put out for you so you can see us in action. Yeah, that's about it. Over the moon about it. I feel absolutely amazing today, same as I did yesterday. Looking forward to it. Can't wait to get out there and go. So.
And then Andy.
We've got 45 seconds, so I can put it on Twitter. Go.
Right, I'm feeling bang on as I usually do. It's fucking buzzing that we're in this. We've been here 12 weeks. It's just like a big family. Everyone was buzzing. Chrissy got himself a bit upset yesterday because he thought he was going to be a nobody for the rest of his life, and me and Jimmy told him, you can be whatever you want to be, and at the end of the day, you're a fucking superstar serving lives.
Yeah.
So we're well proud of George. The manager's just done mint because he even going to give us his office yesterday at the Zoom we recorded. Yeah. So I was proud of him. Adrian's done mint because he come and knocked us up, well, even though I was out. And I could even press my bell for
He got us yesterday though, didn't he?
Andy, how are you feeling today?
Feeling?
Yeah.
Nice.
Nice.
Buzzing.
Yeah.
Happy.
Yeah.
And
raring to go.
And this is what it means to us, man. When you put a couple of hoodies on us that cost £9 each, you show us same respect and hope, and you give us the opportunities to be able to save the lives of our friends, man. It means the world to us. Just one more quick thing. We want to make everyone Naloxone loopy.
Now then, you lovely lot. I'm George from the Harm Reduction Union at Foundations.
And I'm Chris from the Harm Reduction Union at Foundations.
And we know you've been waiting a little while for the next parody, so here's a Naloxone parody in the style of Snooker Loopy. So, Naloxone Loopy pays our way. Me and James and Chris Ricky, we'll show you what we can do with a Naloxone kit when you turn in blue. Twist the kit and you're in. Remove the package and attach the pin. Naloxone goes into the arm. Please don't worry, you'll do no harm. So, if it's tramadol, methadone or smack, don't you worry, it'll bring you back. Get a kit, you'll save a life of someone's husband, child or wife. So listen, Chris, remember, twist the kit and you're in. Remove the package and attach the pin. The Naloxone goes straight in the arm. Please don't worry, you'll do no harm. Have you got your Naloxone? Have you got yours?
I've got mine.
Have you got yours? Carry Naloxone, make a parody. Come on, save lives with Naloxone.
And that's it.
Naloxone
Empowering
Man
people to
loves
save the lives of others is such a powerful way to show people that their lives matter. Thanks very much for your time, guys.
Yeah, wonderful. Thanks. I was laughing most of the time, not most of the time. Wonderful presentation. And what I saw in the chat was inspiring, enthusiastic, convincing, amazing, wonderful, all that. So I really believe if you would sell that wonderful program and technical briefing to the rest of the world, if you can't sell it, I don't know who else can do it. So please go on. And again, I will say we don't have any questions right now. Also, there might be some comments or remarks or questions. So we should go directly to the next speaker. We go to Janko. Are you there already? Just to double check if Janko, are you there? Yeah, Janko should be there. So Janko is based in Ljubljana, Slovenia, and he has a long-standing experience in harm reduction and peer-led initiatives and also naloxone distribution. He works for an organization called Društvo AREAL, which is situated at the squatted factory Roig. Društvo AREAL provides outreach work for homeless people who use drugs and runs a small drop-in center and has also a very small night shelter. And I'm sure Janko can share some more details. Janko, if you can come up with your video so we can see you and hear you. Is it me or can anyone else not hear him and see Janko as well?
His camera and video is showing on unmuted but not working.
Yeah. Okay. So
His end.
I propose then that we go to the next speaker and see if we can somehow solve that problem.
Yeah, Janko, just if you can hear us, you might want to try to reconnect again, because your video and mute is not working. Your microphone is not working.
Okay. So then I go directly to the next speaker. So this is Aura. She's working as a social anthropologist and has a master's degree in criminology and sociology. For the past 18 years, she has been working in the field of drug policy, harm reduction, human rights, and gender mainstream. She combines research with practice, with the development and implementation and evaluation of drug policies and services. And she has worked in Spain, Canada, Colombia, and Costa Rica. 3 years ago, she returned to Barcelona and she did a first study on women who inject drugs in Catalonia. And this was the beginning of Salut, a network of women who use drugs. And 2 years ago, Aura funded Metzineres, which is the first harm reduction program only for women in Spain. So, Aura.
Katrin, and thank you all. Now it's really difficult because after this stellar performance of George, I don't know how it's gonna be. I will share my screen. Let me know if it's working. Okay, here. Okay. Then first of all, I want to acknowledge that I come from a really privileged place. The Catalan government really invested on harm reduction programs 20 years ago. We don't have fentanyl, and also drug use is not criminalized. Then all of these reasons make that the ODs have gone down for the last 20 years significantly. Then this is where I come from, and since 2009, Catalonia has their own Naloxone program. Naloxone is a prescribed substance, but it's given for free to all the participants that go to the harm reduction programs, and they took a training. It's a paid training that you can take in a regular basis. You have to do a reminder course every year, and a full kit is provided, and you can go there to refill it every time that you need, but you have to answer a questionnaire. Then the goal of this program is that most of the people who inject drugs or use opiates or have friends who does have access to naloxone. Also, we have the consumption rooms where are also have also the naloxone programs. No deaths, just in 2019, the number of ODs were 2,024, 0 deaths. Most of the deaths that we have are during the hours that the harm reduction programs are closed. And also most of the deaths are in jail, where naloxone is not available yet. I am talking from Metzineres, that, as Katrin was explaining, is the first harm reduction program for women, only for women, because we realized that women who use drugs and gender non-conforming people don't go to most of them don't go to harm reduction services, either to services for women. They find a lot of barriers, mainly because the harm reduction programs are mostly filled by men. Women just represent the 15%, and they feel that their needs are not taken into account. Then if they don't go to the service or they don't participate to these courses of naloxone trainings. They don't have access to the naloxone training either. What we provide in Metzineres is a full spectrum of harm reduction, including supervised consumption rooms, spaces of all the substances. And we are a transdisciplinary team. Most of the team have life experience and also technical experience. Some of us have been incarcerated. Some have been some of them have been injectors, and also surviving violence. Most of us, some of us are struggling with mental health issues. And what we are trying to do is to implement an integral and holistic approach based on intersectional feminism, human rights, to connect, not just to give some services, but also to connect with the mainstream care networks, and also doing a lot of activism and networking with our neighborhoods, our community, and other grassroots organizations. We are talking about, right now we have around 300 members, most of them cis women, but around 10% trans women and 2% gender fluid people. And we have between 30 and 40 participants every day. A few years ago, we lost one of our members, who is Tatiana, and we began to ask why a lot of our members never took the training. We have to remember that the training is paid. Then we were really surprised that most of the women never took this training. And also some of them had taken the training, but they never carried naloxone. No? Then we were trying to figure out why and what we can do. Then we began to do this training really express, really fast. You can do it in half an hour. Because what we realized is that most of the trainings were done by nurses or by doctors or social educators, and they were using a language and some kind of demonstration that made the women not compelled with what they were listening. And also what we realized is that because the women are not going to the harm reduction services, they don't know about the activities, they don't do the training, and also they don't feel compelled with the information that is given to them. Then the other, we decided that every woman that comes to our place that we know that is using opiates or is with other friends that are using opiates, they will take a really fast naloxone training, and they will have the kit with them. Our kit is really difficult also because we don't have pre-charged naloxone. The needle, you have to build the needle, you have to break the vial of naloxone, which is not always easy when you are nervous. And we have some troubles to find this naloxone, to engage the women with this kind of kit of naloxone. It's because that we prepare new materials. You can see here what kind of tips we are giving. And also we wanted to be really clear about the demands that we have, because it's true that we don't have a lot of ODs right now, but at the same time, we know that most of them are in jail and we don't have access of naloxone in jail. We want prefilled naloxone. We are asking for naloxone without prescription because we think that it's better when other people who use opiates can give the training and we don't depend on a nurse or other staff. Also, we realized how difficult is the injection of naloxone for the neighbors, especially during the confinement. We had some people from the community asking us if we can give naloxone training because they were seeing more people in the streets using and they want to help. Then how useful should be to have nasal naloxone for these people that is not used to inject. Also for families that are also asking us for the training. Now we are working also to avoid opiates overdose. We are fighting for the heroin maintenance program. Of course, we always are fighting for safe supply, that finally this is the most effective way to end with the naloxone. Also with the overdose, sorry. And also at the end, to produce materials that are friendly with the language, that easier to understand. We don't need 2 hours of a training. With half an hour, you can give all the information that is needed, and also in a friendly way. And what we found is after this express training, most of the people, most of the women that go there ask for naloxone, they carry it, and it's more effective. We don't pay the trainings, then how more effective is when they really get engaged with information and not just the idea that we need to pay for the courses. Yeah, this is a small video that we wanted to show. I'm not sure if you can see it. And this is all for me.
Wonderful. Thanks a lot for this fantastic presentation. It's really very impressive, I think, what you managed to do in only a few years. So I think it's as well very much inspiring. And I saw also in the chat, many people responded to your presentation saying the same. I'm not sure if Janko is now in the position to give his presentation.
Yes, do you hear me now?
Wow, yes, you do.
Wonderful. Okay, I'm going outside because inside it's loud. So now you hear me?
We can hear you and see you.
Okay. So first of all, hi, hello to all participants. I must correct you, Katrin. From January on, our office is no more in Aura Roig, so we are now working inside our private flats. So yeah, Aura Roig has been bulldozed by government.
Okay, yeah, sorry.
Yeah, so let's go to the Naloxone project we started in Slovenia. So it all begins from a grant we got from East European Harm Reduction Association in 2017. We begin to work with migrants, and soon we experience some overdoses. And since in that time we still had a doctor, Médecins Sans Frontières, working with us, we decided to begin to carry naloxone with. We organized a few workshops, and from this very quickly situation evolved because drug users community begins to the news spread around. So in one summer, this project explodes in the drug user community in Ljubljana and even a little bit further out to the north. So what is here important? Yeah, we had to have 179 interventions, maybe more, because not all data are now collected because we lost our premises. We are helping as a method or as a how we collect the let's say calls for help. We have two telephone numbers, and we tried a few Google Play applications which are not intended for naloxone but can be used as such. What more? How many? I mean, I don't know what to tell you now. Huh. I mean, this is this is community project which are we working on, and we still don't know how this project will evolve in what, because we don't have office, we don't have premises, and so yes, I hear what.
No, this was just someone entering the
yeah.
Don't worry.
One of the methods how we collect information or disperse naloxone is that we meet every evening when we collect and dispense the food we collect, because we are also collecting food and dispensing it to the people in need. So every evening, another person is in charge of, let's say, inner city of Ljubljana. And as I said, with this taxi central, I mean, with help of taxi drivers, we are able to very quickly react. Where are we getting naloxone? Because this is also a problem. We are getting it from I mean, regularly we are getting naloxone from Italy and also from Great Britain. I mean, from England. Mark Southwell sent me a few vials, and the last few years we are using nasal one, not the one which is in injectable. I mean, in the yeah. Oh, I don't know what more. I mean, it's so hard to present to a project in such environment. It's also cold. Yesterday the snow was falling, so I'm a little bit freezy. I don't know. I think.
No, but Janko, I think that's fine. Will you continue to join the webinar, because there might come some questions afterwards?
Yes, I'm listening. Okay. I'm working all the time, but I don't want that people are. I mean, because it's also the mask is mandatory. And okay, I'm listening, and I will reply to the questions. Just give me 1 minute to go to the location where I can speak with you. Okay.
Thanks a lot. Anyway, for the presentation, I think it's a very good example, very different from the two others we have just listened to. So great, thanks.
Okay, thank you.
So now I think one of the last speakers, we will go back again to Rui, and he will this time present a training course on Naloxone Saves Lives, which has also been produced by EuroNPUD and is implemented by peers and professionals. So please.
Okay, thank you. Well, this course is you know, on the sequence of the technical briefing and all the experiences we and our allies being collected over time. And so very pleased to launch this new EuroNPUD resource, Naloxone Saves Lives Course. Yeah, some slides will be shown in the background, so you can also see this, this light design from Mali, from Metzineres group, from Barcelona also. What the project Metzineres. And the course will teach participants about, of course, opioid and risk of opioid overdose, of course, but most important, it will lead us on a journey to understand and build confidence in assessing and managing opioid overdose, both with people who are unconscious and breathing and with people not breathing. The course ends with an assessment of the different systems you can have of delivery successfully naloxone to the points where it's really needed, and it will highlight the positive impact of peer-to-peer distribution of naloxone, also combating some stigma. So the course was adapted from a work developed by COACT. Thanks Matsaus well for this breakthrough and development, and so we are grateful also to Global Fund and Frontline Aids for allowing us to use this knowledge so that we cannot, so that we are not inventing the wheel over and over again. And so with the knowledge built with the experience and following, UN guidelines, the MCDDA, also promoting other materials done for and by peers, like you do it, I do it from EuroNPUD. Well, as you see, this is a kind of design that tries to bring a more celebratory approach to people who use drugs, but keeping the focus on practicalities and how much important it is for community to have this capacity to save lives. So we have different models. We have one-day course toolkits that includes the trainer's handbook and can guide trainers about delivery of the presentations and exercises and the management of the training process. This training toolkit is available for free, and the idea is that to be used, and it's an open source used to partners that commit that this resource is either used by a peer-led intervention or a mixed peer and professional, and also regarding the audiences, because it's really attacking stigma when we mix the audience, peers and professionals, and in the end you find out that each of us is a possible person that can be in a situation of life-saving someone. Thanks Matt Southwell for all this, bringing all this model and building and busting this strategy also to address stigma. We really tried to have a presentation and a toolkit that addresses all the practicalities. It can be more light and more accessible for peers to use it, and it gives lots of case studies. It gives the opportunity to all people simulate and be aware of all the procedures. beautiful design again. But the important thing is that we're finally over. You know, Katrin again was saying that we are in this fight for since ever, and for 10 years we're trying to produce evidence and to give experiences and case studies of things that work, and peer capacity building and organization capacity building, and people being reinforced on what they already know, but also fine-tuning some myths that sometimes community also has, having all the procedures clearly, understandable by images, but also having this kind of design where it will be pretty easy to change the texts and adapt the texts to other languages, so that it can be a kind of more universal tool for people to for us to spread and try to put pressure on the local level and national level. For instance, in Portugal, and I'm happy also to say that we are translating this for Portuguese, because it's really a nonsense and an absurdity to have syringes programs, to have low threshold programs, and not to have naloxone where it's needed. And in a country that was kind of inspiring with the system of the cream in 2000, it's a bit incoherent, and it shows how much stigma persists, and how much this affects and impacts on people's lives. So this can be more or less simple examples to show and have a concept proofs on how efficient peers can be, and how ready we are to contribute to solutions and to be there and to help our community to not one more death on unavoidable deaths. So now I would leave the floor to participants and to hear some feedbacks and ideas or questions.
Thanks, Rui.
Thanks.
Really wonderful to see, and I think it shows once more how important it is that, or how important resources are, financial resources, and so wonderful to see such a fantastic product has been coming out of this. So what Rui already said, we still have time for questions, remarks, so please feel free to raise your hand. You should all have in the menu at the bottom, you can raise your hand, but probably nothing comes. I know that Matt, there is something. Jakob has saying, what should the activities related to the distribution of naloxone look like in a country where it is not available outside of inpatient care, meaning hospitals or ambulances? Jakob, you would like to ask this question to anyone in particular? No? Because is there any one of the speakers who could...
Yeah, I would immediately think on Janko and how he's been passing between the raindrops, because also on these more tough environments, people have to develop this underground or guerrilla tactics and strategies. Well, despite this, on a more practical and immediate way, as a community, to organize and help other communities, I would say that also on the European level, it would be very important to have standard rules and standards, minimum standards on what countries of EU should follow.
Yeah.
Also, just to comment in that sense, when I was in Colombia, we were opening the first injection services for people who inject drugs. We didn't have anything before, and we had to thanks Dan Vick. We love it, Dan Vick, because his solidarity and most of the community of harm reduction community in the States, we could have the naloxone. They will send it us through postal. They were arriving in boxes, totally illegal, but was saving so many lives just because with this amazing harm reduction family, we always find a way to make sure that the people have what they need, or we almost try. And I wanted to remember just Dan Vick and how he made possible to do all this underground work around the world, no? I think.
Yeah. It's yeah, that's a good example. I mean, it's a pity that this needs to be happening in this way, but I think it's also showing how powerful the harm reduction family, as you say, but also peers are. And even if you look to all the programs we have now been listening to, I mean, for sure there are some kind of resource, there's an increase of resources, but there has been so much development and there are so wonderful services being developed. And if you think how small the amount of money is for these services, that's really something to be proud of, I guess. I'm not sure, Matt, if there are some questions in the chat which are still open, because I wasn't able really to follow up with the chat during.
Just lots of acknowledgement for the presentations from different peers from around the world, and I think a number of people in countries where they don't have access formally to naloxone, asking about this idea of guerrilla programs and how can we support each other. And I suggest that's a conversation we continue on Signal behind the scenes, to look at how groups can support each other to do guerrilla programs where the legal environment hasn't yet adapted.
Yeah. Okay. So no other questions here, or are there probably from the panelists some more comments to make on the presentations from the other speakers, or more in general? I would like to give the opportunity to the speakers at least to have a last word or say something more at the end. No?
Hi, Katrin. Yeah, I'll just I'll jump in and say a few words. I think it's really easy to take for granted. It's certainly in the United Kingdom, how the change in the legislation around naloxone allowed us to kind of really engage and created a really positive climate for people who use drugs to be able to supply naloxone to other people. And I never really stop and think about how difficult it can be in other parts of the world to do these programs. I think I often recall Matt talking a little while back, kind of saying that, like, I'm always really upbeat in my approach, and I kind of think for me that my observation is, like, slowly but surely we're seeing a shift towards
more harm reduction focused way of working, certainly in the United Kingdom. I think for a long time we've been very recovery orientated and abstinence orientated. I think my observations have been certainly from drug and alcohol treatment providers, there's a willingness now to work with people who use drugs to have peer-led projects happening more. So certainly for me, you know, kind of this, I never understood what the word seeding meant. Stephen Malloy always talked about you need to seed into other areas, and it was all a new narrative for me, you know, and I think it's about riding on the crests of waves, you know, so really creating some momentum from one place, looking at Middlesbrough, for instance, right? And then really utilizing like social media. I spend so much time on social media, on Twitter, on Facebook, really kind of cascading messages out there about the great work that peers do, because that creates kind of energy and momentum and excitement. And then before you know where you are, you have somebody getting in touch saying, can you roll this out in our organization? And I suppose from We Are With You's point of view, We Are With You is probably the third biggest UK substance misuse treatment charity in the UK. They've committed to roll peer-to-peer supply out across the whole country. Do you know what I mean? And now next week I'll go down to Wales and work with peers in Wales to a project supported by the Welsh Government, who are prepared to roll out peer-to-peer naloxone programs across the whole of Wales. And I think for me, there's something about kind of challenging that unconscious bias that exists in people's minds. We immediately think that if somebody takes drugs, they can't be in a position to kind of be a volunteer. And I think for me, that's kind of really discriminatory. In some ways, we have protected characteristics around the reasons why we use drugs in any way. But certainly for me, you know, I'm at a place in my life now and in terms of my work where it's no longer about demonizing and shaming other organizations. It's about definitely co-producing and being able to show them a way forward. That the last thing I'll say is kind of the idea of standing on the shoulders of giants. And certainly for me, my work's happened as a result of people on this call, people who are on this call, but who aren't visible right now. But we just have to have hope, keep moving forward, being positive, and believe that change is coming. That's me.
Thanks a lot.
Can I say something?
Yes, Christoph, please.
Yeah, I want to say about George because, you know, it's very inspiring to see George, and it's a guy who is coming from abstinence, and he's very so good harm reduction, and he's making so good work with peers, the people who use, because here in Greece we're still struggling with clean and how many clean and how much clean and who is clean, and this conversation is all making the people worse. We can see people, the drug users who are in the George space, how different they are, and how they start to have to mobilize and to do things from their lives. And we love all these things, and we hope that sometime it will come in Greece also. And because here the doors for the active drug users is totally closed everywhere. Thank you. That's what I want to say.
Yeah, I just saw interesting discussion in the chat going in between. And I see Janko is raising his hand. So just one moment. And there is also discussion why is it so different in the different European countries. I think, yeah, drug policy is something which is being organized and which falls under the national legislation, and there is not a lot of things which can be done by the European Commission or by Europe. But what we have, there is a new EU drug strategy, and the old one is not such a bad one compared to many national legislations. But still, we see that there is many countries don't implement actually the EU drug strategy, and not the EU drug action plan, which has just ended, and there will come a new one, but I'm sure we will see similar things. So there is definitely some things we should use from Europe, and we could probably also use the new EU drug strategy and action plan to advocate and to use as an additional tool. So there are probably ideas how to move on. So Janko, you wanted to say something. I see at least your hand.
Yeah, I just Yeah, I just wanted to say that it's from my perspective. I mean, in Slovenia, we are fighting for recognition to change the narrative of being just a pawn in a game for so many years. So I think that drug users should and must be employed in all organizations, and we must also to take responsibility. Of course, there had been mistakes done, but yeah, that's life. Well, this is my comment.
Thank you. Thanks, Janko. And I just saw that there is also Sarah who wants to say something from the participants. So you can unmute yourself and.
Oh, sorry. Yes, I just wanted to. I have a question for Janko because I heard that he said that he's working from his apartment, like from his home right now, because I know that in Slovenia they evicted the Rog, which was he had his office there before, but now I just wanted to ask him what is his plan. I mean, the political situation in Slovenia is it's a catastrophe, you know, and I just wanted to ask Janko what are his plans for the future, because he's very much needed, you know. That was my question for Janko. Thank you.
Thank you, Sarah. Janko, could you respond shortly to the question of Sarah?
Oh my God. No. Okay.
Janko?
Maybe he didn't hear. I think he said goodbye. Oh, yes.
Oh, here he is.
Oh, there he is.
Janko, could you shortly? You must unmute yourself.
Do you hear me now?
Yeah.
Well, I think we must not fall into despair. I mean, it's if you look into the history, so many times. Sorry.
Just continue.
Do you hear me?
Yes.
Yes,
yes,
we must join forces with the progressive part of society.
We must join forces with progressive part of society. Don't fall in despair. I mean.
Yeah, I see somebody commenting in Slovenian language.
No.
Yeah.
No. Oh, it's
okay.
I understand.
Well, the situation.
Yeah, I think it's a difficult situation now in Slovenia, but it's good to hear that you. You don't want to fall in
the situation in Slovenia is not nice. I mean, also harm reduction in Slovenia for many years is alienated from its core.
Yeah.
So we must include drug users. That's it, I mean.
Yeah.
I mean, that's it.
I understand. Yeah. Thanks for the feedback.
Thank you.
So given the time, I think we need to, close the discussion. And I would like to thank all the speakers for contributing and for sharing their knowledge and their experience. Thanks a lot. I think this was wonderful and very inspiring from all of you. Also for EuroNPUD to organize that event. And I would just give you one more reminder there will be 2 other sessions in the next forthcoming 2 weeks. I'm not sure if Rui or Matt want to say something about that. For the next 2 weeks, what will happen there?
Yes, so next week we have the same time, the same slot. we have a focus on secondary needle and syringe programs. So this is various different needle and syringe programs run by people who use drugs. And then at the same time, we'll also launch our new the twin resource, which is a training toolkit on safer injecting. So that will be the focus of next week's work. And we have, again, a number of different countries coming to show case studies of this type of work. The week after, again, at the same time, we have a webinar, which is a partnership webinar, which picks up on the global consultation on peer work. This was a project that EuroNPUD partnered with MDM, INPUD, and 2 sex worker networks. And there was a consultation and focus groups with, well, 17, I think it was 15 focus groups in 13 countries around the world, including 2 from Europe. And that led into a global consultation with about 70 invited partners from key technical agencies. And also the whole process was led by peer workers from working with sex workers and drug users. And that is trying to review where are we with peer work at this moment in time, what's the learning, and how do we need to make changes to make this a more equitable and sustainable model. So that was a closed consultation with just a closed invitation group. So the last webinar in this series is a chance for the partners in that process to feed back, and Judy Chang from INPUD will share some of the really interesting research that INPUD was involved in understanding peer work in the Global South. I will share some feedback from the peer work, from the focus groups, and then the Ernst Weiss from MDM will introduce a cartoon video that captures the learning from the webinar series. So look, we think both are really important events, so please come along and join us. Thank you for joining us today.
Great. And probably, Matt, just one more question, because I saw that Aura is asking if the EuroNPUD toolkit could be shared with all participants. I think they will be available, or how?
Yeah, so basically the way this works is that the resource is open source and it's available for free, but on the condition that it's used in a particular way. So the expectation is that the training must be done either by peers or by peer and professional partnerships, and the audience must either be peers or collaborations of peers and professionals. So we would want people to sign a partnership agreement to guarantee that it's going to be used in that way. We will obviously help with translations in the European context, but if other partners can afford to fund their own development work and want to use this resource, then we would be very happy to form partnerships with either drug user organizations or with professional and peer partnerships.
Great, thanks. So they should just contact you or someone else from EuroNPUD.
That would be great, yeah.
Thanks. So then I think we are more or less done. Thanks again to everyone, also to the participants, and again for the wonderful presentations. It was a great event. Thanks a lot.
Thank you so much.
Goodbye,
Thank you.
everybody.
Thank you.
Good, perfect.
Yeah.
Bye-bye.
Thanks, everyone. Cheers.
Bye-bye.
Bye, ciao.
Send regards to Naloxone Man.
Yeah. Ciao. Bye-bye.
Ciao. Bye.
Ciao.